Nathan, thank you very much. Thank you, Sages, for the invitation. It's an honor to be here to present and debate against one of my good friends from Colombia. So I'm going to talk about bilateral recurrent hernias should be done only laparoscopically. So these are my disclosures, nothing to do with my talk. A little bit about general things about growing hernias. Over 2 million hernias are repaired worldwide, around 800,000 in the United States, even though 25% to 30% are being done laparoscopic. So there is a lack already of training, in my point of view, of why only 20 or 35% of these cases are being done laparoscopic. Very low complication rates. Recurrent rates are 1 to 2%, and still has some complications, chronic pain. So where do we sit laparoscopic inguinal hernias compared to different laparoscopic approaches? I think that it's an intermediate procedure. So many authors have studied the benefit of laparoscopic versus open techniques, quality. This study, Dr. Myers in 2010 published 90 patients on each group, and definitely laparoscopic has less pain and faster return to regular activities and similar recurrence rates. TAP versus open has level 1 evidence that pain in the first 6 weeks definitely was in favor of the laparoscopic in a randomized trial of 400 patients. And this is another study from the Look that presented his experience with over 3,100 hernias, very low complication rates, intra-op, post-operative complications, and very low recurrence rates. So can we put some volume here, please? So when we're done with training in general surgery, definitely we have all this information and we're thrown to the real world where many surgeons have criticism against our practices, techniques. But I'm just gonna see if I can put it here. Well, I don't know what happened, but he had it in my computer. But regardless, when we are starting our career, we want to practice the medicine that we were taught in residency. And I remember that the two main indications that we always had in mind for laparoscopic inguinal hernias were recurrence and bilateral inguinal hernias. When we talk about unilaterals, we were in that gray zone, correct? So we start with a plan, and we start from a starting point and we want to get to an end line. How do we do that? We start looking at the major surgical societies and recommendations and guidelines. So we look at the SAGES, American Hernia, American College of Surgeons, International Foundation, many institutions. And then we start looking at the main professors, the big ones, the ones that we're going to follow. Conrad, Dr. Felix, Dr. Jacobs, Dr. Rosen, Dr. Ponsky. And then we start looking at videos, and then we're just going to start putting a plan together. But when we start looking at all these videos and the plans, they seem very easy to reproduce, very easy to duplicate. So if I can grab my bike and start doing this as easy as this guy is doing it, then I already win the fight against Dias, correct? But let's talk about true facts. Dr. Dias is Colombian. It's an expert in inguinal hernia. It's a pioneer in ETEP. It's a great mentor to many, and it's a great friend to a lot of people, including myself. I love me. That's a fact. Dr. Dias mentioned the world guidelines of growing hernia, that it's not published yet. It's a draft. And as Dr. Dias was saying, provided the resources and expertise, laparoscopic should be offered to these patients. So if we don't have the expertise and if we don't have the resources, like most of the countries in Latin America, then should we offer this surgery to our patients? This is exactly how the chapter looks like. And looking at the greatest and biggest societies in America, if you look at the SAGES Manual of Hernia Repair by Dr. Brian Jacobs, it says in the recommendations, open repair, large scrotal hernias, patients cannot have general anesthesia. Look at the laparoscopic repair. Recurrent, bilateral, woman, that I'm not going to debate this with Dr. Dias, and sports hernia. But when you talk about laparoscopic versus open in an uncomplicated unilateral, should depend on the surgeon's experience. If we look at the European Hernia Society, the recommendations are all males symptomatic above 30 years old, recurrence, bilateral. Doesn't say anything about unilateral. Curry studied 21 randomized trials, over 4,200 hernias, and in 10 out of the 15 trials, TEP had increased OR time, 6 out of 11, shorter hospital stay. So he concluded that TEP involves more expenses for hospitals, but better cost-effective for the patient. Dr. Felix in 2005 put this paper together about the meeting and debate on inguinal hernias. So 15% of the hernias at that time were done laparoscopic. For open surgery, low cost, technical was easy, local anesthesia. So those were the major ones. And laparoscopic, superior cosmesis, less pain, faster recovery. But at the end of his conclusions, look at this, could not settle in this debate. So it's already there. This group in Germany compared his experience with 2,800 hernias versus other articles, 10,000 patients, when patients presented with bilateral and who had open repair primarily or stage second repair. And he concluded that bilateral inguinal hernias should be repaired laparoscopic. This group in Italy studied 7 randomized studies, 647. All these patients had recurrence, 2 groups, and their conclusions was that laparoscopic showed reduced chronic inguinal pain and earlier return to normal activities when it was done laparoscopic. This Spanish surgeon in the European Endoscopic meeting, he submitted a questionnaire to 100 surgeons to see what type of practices they were performing in their countries. And you can tell bilateral, 93% versus 7% open, recurrent, 81 versus 19, primary unilateral hernias, still all over the world, over the field, 30% open, 39 TAP, and 29% TEP. So what is the myth about this debate? That definitely surgeons do not follow the rules right. When we want to take parts from this and take these recommendations and the standard of care, but at the end of the day, we're going to do whatever we think that is best for the patient, correct? So that's the myth. Concluding to this is that laparoscopic repair should be reserved for bilateral and recurrent inguinal hernias, and choice for the uncomplicated inguinal hernia repair should depend on the surgeon's expertise. Thank you very much.